Well, I really want to thank you so much, Deb, for bringing together just such a fantastically diverse and interesting group of thinkers in this area. And our panel is going to talk about the upcoming revolution in AI. I may actually sort of step on the panel title a little bit by beginning in that I have been focused recently on the potential overclaiming for AI. And I think that, it's important that we all have sort of a sense of what's really plausible within 5 to 10 years as opposed to, say, 40, 50, 60 years or the Ray Kurzweilian singularity. And so that's one emphasis that I've made in some recent reviews of books by Brynjolfsson and McAfee and Susskind's The Future of the Professions, which I think is very interesting and thought-provoking in many of these areas about the line between the professional expertise and the role of software coders and others and researchers in improving how professions are run and how well they serve patients and others who are served by them. So with that, I just will do very brief introductions of our two panelists for this afternoon. We have, first of all, we'll be going ahead with Christo Wilson, who's an assistant professor in the College of Computer and Information Science at Northwestern, whose research is focused on algorithmic auditing, the science of examining these black box systems to understand how they work, the data they use, and how these algorithms impact individuals. And having just come back from some meetings in London and in Brussels with the European Commission on the future implementation of the GDPR and the role of auditing and accountability and intelligibility in algorithmic decision-making, I think this is incredibly important work. It's also incredibly important and exciting because it brings together attorneys, computer scientists, social scientists, journalists, and others. And I think it's only through that type of teamwork that we're actually going to have an accountable, humanly intelligible future, as opposed to one where machines are making a lot of decisions without real accountability or explainability. Our second panelist today will be Adrian Gropper. Of course, in this room, everyone knows Adrian as the MD and CTO of Patient Privacy Rights, who's done incredible work with patient privacy rights for all these years. And so it'll be great to have his perspective as well. So we'll begin with Christo. Thanks.
Well, thank you very much, Frank. And I'm thrilled to be here today to talk about some of my work and talk about AI in general. So as Frank said, my research in recent years has focused on algorithmic auditing. So we are constantly sort of surrounded now by algorithmic systems that help us with our day-to-day lives. Nobody knows how to drive places anymore. We just pull out our phone and Google Maps tells us where to go and how to get there. You don't have to search for books or media anymore. We have systems like Netflix that will recommend things to you, exactly what you'd like to watch right now. And by and large, these systems are nice. We like the convenience they bring. They're designed to delight us. But there's potentially, a dark side to any sort of tool that's widely deployed like this, right? So if we're talking about these algorithmic systems, it's very rare that we understand what data is going into them, how the system is being implemented, and ultimately why it makes the decisions that it does, right? These are often developed by companies. There's trade secrets that prevent us from understanding how these systems work. So my goal is to try and increase transparency of these kinds of algorithmic systems. So I believe that people should understand how their data is being collected and ultimately being used by algorithms. So to do this, we borrow some methodologies from the social sciences. So this is the classic audit study, otherwise known as a correspondence study. So you've probably heard of studies like this. So a canonical example is one where a researcher will say, I want to know if a company has discriminatory hiring practices. So the researcher will send a bunch of resumes to the company that are all identical, except for the names, right? Some are men, some are women, some are Caucasian, some have Hispanic names, some have African-American sounding names. And then you wait and see who gets callbacks. And in doing this, you can actually uncover, systematic discrimination. If only white men get calls, this tells you something about the corporate culture at this company. So we're applying these same kind of techniques to algorithms, right? If you think about a website or an app, we can interrogate it. I can recruit people to use the app, and I can have the people fill out a survey so I know something about them, and I can record all the information coming from the app. I can also set up fake accounts with very specific characteristics, and use them to interrogate the system. And by collecting all this data in a carefully controlled way, we can start to draw inferences about how the system is taking in data and how it uses it to produce outputs. So to give you some examples of things we've done in the past, we had a study looking at online price discrimination. So how e-commerce sites use information that they know about you to alter prices. Right? So everyone thinks you go on a site, all the prices are the same for everybody. That's not necessarily true anymore. We've had some success also looking at things like Uber's surge price algorithm. So for those of you who've ever used Uber, you understand that the prices for cars is not a flat rate. The prices vary based on supply and demand. But of course, we have no idea how this system works, and it turns out that the incentives that they use are sort of warped, and it doesn't work quite the way that people think it does. So ultimately, we'd like to move into other spaces as well, including things like healthcare. Right? So how are people collecting patient data and using it to do predictive analytics? And are those decisions correct? Are they meaningful? What is the data? How is it being used? Is there bias, et cetera?
Great. And so next I have some questions on all of those projects and how they relate to healthcare. I'm going to be giving some very concrete examples, but I next want to have Adrian give your presentation, and then I'll have some questions and then open up to the audience.
Thank you, Frank. I'm going to be as brief as Christo was, partly because I did not prepare a presentation, but also because I think this is a topic which the conversation and Frank's moderation, I think, would be much more interesting. I want to talk about AI not in the sense of what's going to happen 30 years from now, or whatever you put it. It's always 30 years from now, and right. For certain things like voice recognition, it was the classic example. So I want to frame the conversation about AI by reminding you of the fact that IBM Watson was introduced to the world playing Jeopardy. Right? And they weren't able to be on the panel today, so I'm a very poor stand-in for the Watson representation. I then want to draw your attention to the movie, which wasn't my favorite movie by any means, Slumdog Millionaire, where during the Jeopardy-like quiz show that the whole thing is about, there's a lifeline. He doesn't know the answer. The second question is he uses the lifeline. It's an incredibly tense moment. And to frame what we're going to talk about today in the sense of what I'm calling independent decision support at the point of care. So if you want to think of that Jeopardy moment, of that Slumdog Millionaire moment as the point of care, a licensed physician, a patient making, life-changing decisions. Where does the decision support come from separately for the two of them? The doctor wants to do a good job. The patient has different concerns. And what does it mean for that decision support to be independent or to be transparent in the sense that this panel is about? And let me basically stop there. Obviously, I'm prepared with my engineering hat on to talk a lot about what's going on today that impacts this ability to provide independent decision support, whether it be from Watson or from GoodRx, which is an example we've prototyped as a proof of concept, where it just tells you how much the prescription costs at 10 different, and again, there's a transparency issue. Who's paying GoodRx to give you those particular 10, and why isn't Costco Pharmacy, which is number 1 or 2 on the Consumer Reports list, part of that list? All the way to obviously second opinions that are going to come from Watson and that pretty much everybody's going to want to buy from various perspectives. And how many different second opinions do you get, and how do you tell them apart using the models?
Great. So just to make this really concrete in terms of the data protection issues that could be raised by predictive analytics in healthcare and AI, I'm going to go to an example that was raised in Health Affairs in July 2014. They had a great series of pieces that had John Halamka, Glenn Cohen, some other thought leaders on the future of technology in healthcare, on direct deployment of these systems. And let's say you had in the hospital, the nephrologists wanted to process all of the records of people who had impaired kidney function, and they find out that of the 1,000 patients at the hospital, according to their risk scoring model, 15 of them were at highest risk. Now, one question, and they decide with those 15 people, moving from data to knowledge to action, they decide to call them up and say, please, call your nephrologist, come on in, we want to sort of have a special look at you or perhaps have other interventions. One question would be, do you think that it's ethically obligatory or recommended that they disclose to the people exactly how they were recommended for the intervention or the call? The second question would be, is there any obligation to talk to the next 15 people who didn't get called in, but who are still in, relatively close to that danger zone? When we talk about, and this I think relates also to Deb's excellent work in the EHR realm back, in the 2009 ARRA, in terms of thinking about accounting of disclosures and, what does it mean for people to really understand their full health record? So just thoughts on that, any responses?
Well, let me go first and say I would reframe the question, or not to duck it. You asked the question in an ethical context, and I'm going to answer it in an ethical context, but from a different perspective. I would say, what part of medicine, whether it's machine intelligence or whether it's databases created as a proprietary trade secret by Foundation Health, who just went public 2 weeks ago, or anything in between, what part of medicine do we abide as secret? Is there any part that traditionally has ever been secret? We've had patents, we have intellectual property. You can't copy a journal necessarily, but and so as I hand off the question to the algorithmic transparency person, this is my way of ducking it, meaning that I think the answer to your question depends greatly on what the reason, how much of medicine is secret, given the tools that they use to pick those 15 patients. In other words, could there be other people that make that decision about which 15 patients and the next 15 patients? Or was that the fact that you're a patient at Mass General Hospital and they have their version of Watson and it's not Cleveland Clinic's version, and that kind of thing?
Sure, yeah.
So I think this is a great starting point, for the discussion. Suppose we took your context, Frank, and replaced kidney function with something like risky sexual activity. So we want to bring in the top 15% of people who we believe are engaged in risky behavior to do an intervention. Right? All of a sudden, we've gone from a context where maybe you'd think, okay, the ethics are pretty clear here. We're just going to go out and help people based on risk scores. And now we're talking about a much more sensitive topic where people would absolutely want to know, well, why do you think my behavior is risky? Like, do you have some kind of deviant detection algorithm? I mean, this is very, contentious stuff. So if we're going to move into this realm where we're going to have automated decision support systems, my default position is transparency. People should know why they are being contacted. And the hope is that people at least understand where the data came from that went into the system in the first place. So they're not shocked by this phone call and the doctor says, well, we have all these EHR records from you and we did some computations. And the person says, huh? Where did this even come from in the first place? I imagine that people would find that to be pretty jarring. Perhaps not in this audience where we understand that these records are digitized and moving around and available, but amongst the general public, I don't necessarily know that understanding is there. So then with respect to okay, we're going to notify the top 15%, what about the next 15%? Anytime you move into this situation with a decision support system, you run the risk of automation bias. So this is a well-known effect where you start to rely more and more on the machine or the form that you filled out or whatever the algorithm may be to sort of outsource your decision making, right? You no longer apply your own critical thinking skills. You just do what the machine tells you to do. And given that these systems are fallible and not 100% precise, setting an arbitrary cutoff, let's say at 15%, you're setting yourself up for trouble there.
Okay. I do think, that I want to get back to that question of the combination of automation bias and skill degradation, because in the literature on automation that's really nicely summarized by Nicholas Carr in The Glass Cage, he looks particularly on some of those issues of, are we setting ourselves up for denying ourselves a pipeline of future professionals by overly automating and outsourcing the thinking process to either software or other data-driven systems. I want to also get to this point that you raise, Christo, in terms of extremely sensitive health data, right? Because we already have within the health data regime, it's a complicated regime that involves both federal and state law. Even within federal law, there's certain call-outs for certain forms of sensitive health information, which I think include children's information, sexually transmitted diseases, substance abuse, genetics. I think there's one more. And so there's these call-outs for very sensitive data. And I want to give to both panelists sort of a contrast between two ways in which this was handled for suicidality data. And I think this may have been even mentioned in the last panel. Someone said they did some work for the VA on helping soldiers and trying to identify people that might be at risk of suicide. And I think that's called Project Durkheim. And it was essentially an opt-in system where the veterans could say, please monitor my social media posts. There was an existing corpus of training data that was based on the social media posts of veterans who had committed suicide. And to the extent the people who opted in, their postings matched or otherwise were predicted from the machine learning training data that they were they were in a danger zone, they were reached out to and they were referred to psychiatrists. Now that, I've seen many positive discussions of this in literature. Contrast that with something called Samaritan's Radar, which I believe was a British charity that sort of on the basis of people's tweets would, without opt-in, reach out to them and say, oh, you look kind of depressed from your tweeting. Is everything okay? And and certainly we've even had news today in terms of Microsoft saying that they could potentially identify indicia of cancer from people's searches, right? And so I'm wondering, are those two approaches, are those sort of cautionary? One is a cautionary tale, one is sort of a potential best practice, or is there a deeper complexity that the common literature and narrative is not getting there? Either.
All right, I'll start. I would frame the question not in terms of having anything particular to do with sensitive data or not. That's a subtlety to the question I think you're asking, or at least the way I would frame it. I would basically say, how do you regulate systems, algorithms? How do you regulate algorithms? And what happens to the role, the regulatory role of the physician, of the licensed practitioner, when you have something like Watson able to pass the internal medicine boards, whether that's apocryphal or already doable and they're just not a good marketing move, I don't know. But there are not many people that would doubt that, that Watson might be able to pass the internal medicine boards. So do you issue that machine intelligence a license? I claim not. I claim that technology needs to be licensed the way you license drugs and devices, and we have good experience as to what that means, and that the role of the physician has to remain as the agent of the patient and regulator responsible at the edge of the network, if you would, separate from that. And only the relationship of the patient and the physician to the machine intelligence is going to shift. But so in other words, it's not about what the nature of the data that's going into the algorithm is, whether it's sensitive or not. It's a regulatory issue that we want to pay attention to make sure that we have that human component for safety reasons and ethical reasons, able to continue to do that professional job.
Great. And Christo, any thoughts on that?
So I very much agree with Adrian. The regulating of algorithms is going to be an extremely complicated endeavor. But Adrian raises great points about the issue of accountability. Right? If an algorithm makes a prediction and says, "Okay, give them drug A," and that ends up killing the patient, right? Who is held accountable for that? Is it the doctor who stuck the syringe in? Well, they claim, well, I was just following orders, sort of, for better or worse. Who do you sue when it's Watson is the doctor? Is it IBM? Well, they're not doctors. But getting back to the issue of the data itself, whenever we talk about privacy, I think it's important to mention Helen Nissenbaum's work on contextual privacy. So Helen has done a fantastic job of trying to get into the vagaries of how people perceive private data. We tend to think about it in terms of silos, like financial data is more sensitive than my social media data, which is itself more sensitive than my health data or whatever. And it turns out that that's not really true. So even if we're talking about a specific piece of data, like a health record or your bank account information, your perception of how sensitive it is varies depending on context. So for example, if I walk into a bank and I ask for a loan and they ask for my bank records, right, I would expect that. I would say that's not a violation of my privacy. But if I walk into a company and they say, we are interested in hiring you, but first we want to check your bank statements, right? Same data, but now I feel completely violated, right? You have no right to see that information. It's not important in this context. And the same applies very much to health, right? There's absolutely contexts where you expect to need it and give it. And there's other cases where you don't expect the data to appear or be germane, and yet it is perhaps being used in those contexts. So there's a lot of subtlety to the data and contextuality that is often lost in this discussion.
I do agree with that. I mean, I think that's a really important angle to consider. That certain types of data people will be very happy for certain folks to see it and not so happy for others. One worry I sometimes have about that is it a lot of labor to keep track of all that? And who exactly is going to be doing that labor? Which leads to another question. Oh, and by the way, I also want to note, before getting to my next question, I want to note something that you mentioned about the liability questions, and to give out shout out to my podcast co-host, Nick Terry, who's going to be on the next panel. He's done co-authored work on robotics and law. And I think that sort of if you want to look at a good article by him and Simshaw and some others on how we determine who's liable and who's not, because there's this very interesting tension where there's a learned intermediary doctrine, which tries to immunize the people who are making the equipment, right? Mm-hmm. But to the extent that they're saying this is not just a tool that's used by the doctors, but it is itself a machine that can do things of its own accord, that it's coming closer and closer to a brain, which is sort of the argument of some schools of machine learning, then they've got to take on the responsibility for sort of saying it has that level of personhood. My next question is about, in terms of the regulation of the algorithms here. In the legal literature, there's a lot of activity here. So for example, Andrew Tutt has written an article called "We Need an FDA for Algorithms." Okay. Others, Ryan Calo has written on a Federal Robotics Commission, and that has come out as a Brookings Institute paper. So there's certainly some people pretty high level in the think tank world that believe in that. Others have called for a Federal Search Commission. Okay, well, that was me. But which to follow up from a Federal Communications Commission. So I'm just wondering, in the regulatory landscape here, is this something that you could see something like FDA sort of making really meaningful interventions in terms of assuring the safety of the clinical decision support software or other things that would employ artificial intelligence? Or does it seem as though the agency is just overwhelmed and it's not really appropriate to add this to their plate?
Well, we can get into the issue of whether they have the funding to do this, or perhaps even the expertise, right? If you're going to evaluate the algorithms, you need a bunch of machine learning people, you need statisticians, and it's not necessarily clear that they've got enough computer scientists on staff to do this. But in principle, given the resources, I think they absolutely could. And I would urge that they should do this.
Yeah.
If my gut instant answer would be no. They are not set up, and they may never be set up. That said, I would nuance that by saying that they are the only people who are in a position to tackle this issue. We're not going to create some other agency. We're not going to go to the EU and they'll figure it out instead of us. Or, which, there's this tension between how we regulate things here versus the rest of the world. And so what I'm trying to say is that I think the role of the FDA will shift to be more like what we have with NIST in the cybersecurity, identity, privacy world, where NIST is not a regulatory or enforcement agency either, but they are expert and support the people that they support, including the FDA. And so the way they support them is by introducing process into the kind of decisions that are made. And it was alluded earlier in the previous panel, my work with IDSG, which is basically seated NSTIC on identity cybersecurity issues. And NIST plays a central role in that. So we have now, in my experience, probably 4 or 5 years, it could be a lot longer, I just wasn't paying attention, of tradition or experience with NIST trying to do this. And it's a very hard thing to do because it ends up like with IDSG and trying to create public-private partnerships. And those governance models, as Daza alluded to earlier, are very difficult to move. So the agency will change is what I'm saying.
Right.
But it will be the agency.
Great. And I want to get to another issue, in terms of the data and the going into the training of machine learning systems and an AI. One of the biggest problems in the health data world, which is a problem of bad data, right? Or data that is just sort of, we've heard repeatedly that after the implementation of electronic health records, a lot of doctors use the copy and paste functionality and just end up copying and pasting the same set of things for patient after patient after patient, just because the time is not there, or it's just too stressful. They've added this whole documentation role to them. And I'm wondering, is this something that the AI literature is trying to think about? Are people in machine learning trying to think about there is this problem of junk data that's being fed into the training sets for machine learning algorithms? Or is it one of those areas where the basic dogma is big data is so big that the noise cancels each other out? So any thoughts on that?
So this is absolutely, a problem. Computer scientists talk about garbage in, garbage out, or GIGO, and it's exactly what you're talking about. If the data is not good, you can't possibly expect the system to make reasonable decisions. So there are certainly people in the machine learning community who are acutely aware of this, and they're the people who are sitting on program committees, rejecting papers where the person says, okay, well, I had data on 1 million people, and therefore my conclusions must be right. Well, big does not mean representative or unbiased. Statisticians, people trained in the humanities, actually have a better understanding of some of those issues. So, that said, right, I think academics understand we have this quality problem. But when you move into, let's say, Silicon Valley, where you sort of have this move fast and break things mentality, often this gets lost in translation. So it's wonderful that there are capabilities like Watson and other machine learning platforms that are so sophisticated and so easy to use. But at the same time, if you have non-experts taking poor data, putting it into Watson and then saying, okay, great, now I have a health product that I can sell. Again, you're setting yourself up for failure and potentially real harms here. Which gets us back to this issue of regulation, and should the FDA be looking at things and certifying them in some way to make sure that it's not just that the software is functionally correct, but also that the data that you used is reasonable, unbiased, representative.
Great. Adrian, any?
You've asked the question that I think is at the center of my work on privacy from what I try to do, because I see this machine learning or this issue as the thing that is going to drive privacy in the healthcare space and maybe beyond for the future. In the following sense, the data is the software, is the algorithm for pretty much all. And I'm not an expert, but Christo is, and he's shaking his head. So. What this means is that, so it sort of ties together, first of all, what's intellectual property, what's secret in a world where the data is actually the algorithm. Never mind how you regulate it, which is the question we talked about before. If the data is the software, and you have your question, the way you phrased it was beautifully, about big data, it'll all sort itself out. The next thing that happens is this issue of sovereignty, which Daza introduced and actually goes back to the guardian angel things. And if we had time, we could go into, and maybe a little bit in the next panel when we're talking about sovereign personal data stores, et cetera, the Apple panel. So what I'm saying is that when data is the machine, people will then have an incentive to game the system in order to maintain their sovereignty. It will not be accidental. It will become intentional. I was born in Eastern Europe. People would do that routinely, and I think it was actually Joe yesterday that alluded to what happened when the Eastern Bloc joined the EU. And so, it really is the privacy issue of the coming time.
Yeah, and I mean, I also wanted to note that, we so often hear in pushback against privacy regulation that it's impeding innovation. But to the extent that we can emphasize that privacy is empowering the patients to ensure that the data is actually accurate and useful, in that way, the two things come together. And you see that in Victoria Stodden's work on reproducible computational science. You see it in many other areas now where it's really seen that privacy and innovation come together because you've got to have good data to run these things.
Right, but I would simply emphasize the fact that it has to come together at the patient. It does not come together in the data oligarchs or in the corporations, regardless of how you regulate them. They will need to be regulated, as we talked. But if it doesn't come we just basically have to ask how soon before it comes together at the patient.
Right.
Not if.
Well, I have more questions, but I just want to open it up to some questions from the audience because I see some, because I saw some experts approaching the mic. So yes, Nick, yeah.
All right, so obviously the FDA currently regulates things like clinical decision support system, and you could sort of view Watson as being kind of a supercharged version of that. But famously, FDA does not regulate the practice of medicine, how doctors regulate. So is there a point in time or a place of a development of AI in healthcare where the FDA is going to have to step back and say, this is now practicing medicine and is not merely a device, and then shifting into state law, is this the practice of medicine under state licensing, or will we have long since abandoned those legal paradigms before we reach this point?
Questions? Any thoughts?
So ultimately, I think they will have to reevaluate how they regulate. Because at some point you will have someone who tries to use a neural network to make actual clinical decisions, right? This is the drug you should give this person. And at that point, we start getting into very thorny accountability issues about what happens when mistakes are made. Do you trust the system the same way you would trust a doctor? And And it's not sufficient to just say, well, it's software, it's always right, right? We subscribe to the big data, and big data is always right. And we know that that's not true. So I think they're going to have to evolve their approach eventually.
I think the technology will be so far ahead of the FDA that it really is an almost irrelevant question in the sense that, Blade Runner, for example, where where do you put regulatory systems in a global information-based thing? I mean, there's absolutely no barrier unless you don't control your own health records, your own attributes, in a way that you can expose these to whatever machine intelligence decision support system you pick, wherever, it's in China, it's where medical tourism if you need to. So I think we will see a narrowing of what the FDA can regulate. They'll be able to regulate commerce if they can. Again, the dark web will probably play a role there. And that's about it. So I think the technology is already very close to outstripping that kind of regulation. And so again, they become more like NIST in giving good advice, like public health, brush your teeth type of things. But I don't see how they could possibly do it. It's just information.
So let me, I think that actually, with respect to Nick's question about this relative allocation of authority, I think it is very important that we preserve a role for state licensing organizations to move in when there are claims, very expansive claims made, as eventually there will be, that the AI is a doctor. I recently saw, just to analogize from law, there was this spate of stories saying that a law firm had just hired a robot lawyer. Okay. Of course, you look behind the story, and it turns out, what it is just slightly better software than the usual software the lawyer uses, right? And so, what that reminds me of in the medical context is the FTC's intervention with respect to Mole app. So there was an app that, they said, take your phone, take a picture of your hand, and then we'll compare it to a database of moles, and we'll see, maybe it's melanoma, maybe it's not. And this Mole app was told by the FTC, this is deeply troubling. You've not substantiated your ability to make this type of, if not diagnostic, quasi-diagnostic recommendation or information. And I think we can't live in a world in which we simply allow entities to say, well, we're like a book, so we're unregulable. We're information, so we're unregulable. We really have to be able to step in. And, when they say, and this difference is really critical for the points that Nick raises, because when somebody puts forward says, this is your doctor, then we want to know, does it uphold the ethical standards of doctors? Does it have fiduciary duty? Where is the liability? What happened to the learned intermediary doctrine? It's the perfect recipe for avoiding all responsibility. If you say, well, there's no learned intermediary to hold responsible, but then we're not holding it responsible either because it's just speech, then that really creates a huge black hole of unaccountability. So I'm sorry to sort of rush in there, but I sort of feel like it's important to lay out all the potential problems there. My last point would be that the worry I have is, even though I'm calling for the state boards to step in, the Federal Trade Commission has been very skeptical of professional associations recently, if you look at like the North Carolina dental case. So the worry I have is that essentially you have an FTC that sort of is a bit too enamored of digital technology, stepping in on behalf of so-called disruptors, permitting them to enter markets, if they see it as potential antitrust violations. So, yeah. But over on this side, yeah.
So,
No.
Can people hear me? No, wait. Didn't use it. So I have two closely related questions. One, Bill Yasnoff, health IT consultant and faculty at Johns Hopkins in health sciences informatics. I have two closely related questions. One is, are there currently reliable and effective methods for assessing the validity of algorithms? And closely related to that is, what's the role of an algorithm's capability to explain its output, and how does that affect the development of algorithms?
Yeah, so the two questions are, one, how do you assess the correctness or the output of the... Yeah, so can you evaluate the accuracy of the algorithm or evaluate its output? And then the second question is, what is the role of interpretability? So does an algorithm have to explain its decision-making process? So in terms of evaluating accuracy, this is a very thorny problem. So computer scientists very much like things that are cut and dry, that you can specify in code, problems that have sort of clear mathematical underpinnings. And this is much more complicated when we start getting into human and value and even moralistic decision-making processes. Because how do I teach a computer those things or evaluate its output along those axes? So in general, this is a very hard problem. You can sort of take a statistical approach to it and say, this algorithm is supposed to do X. Right, let's look at population statistics, let's interrogate the system and try to audit it and understand what are the decisions it's making relative to some baseline population or relative to some objective that we've set. Maybe it's a non-discrimination rule or something. But we'll never know for sure that it will always obey these kinds of fungible rules, because you start getting into the limits of what we can say definitively about computers in general, which is that you can't precisely say anything in general. So as to the question of interpretability, I think this is really important. So if we're talking about machine learning, there is a wide range of tools available, some of which are interpretable. You can look at the model produced by the software. A human being can look at it and understand this is sort of the decision-making process that you've learned, and why did you learn it? So if we're talking about something like an FDA for algorithms, this is potentially something that they could push, right? If you want fast-track certification for your system, use an interpretable model, because it's that much easier for us to audit it and determine why is it going to do stuff. Alternatively, there's certainly models like neural networks that are uninterpretable. They're so complicated, nobody can understand why it's going to do the things it's going to do. And if you ask why, well, think about the most complicated neural network in existence and try to figure out why it does the things that it does. The mind is inscrutable. So if you're going to move forward with a system that relies on an inscrutable model, now you set yourself up for more scrutiny and more evaluation, potentially a slower licensing process, because the process of trying to evaluate what this thing's going to do is going to be that much more belabored.
I'll just disagree in the following sense. It's just medicine. Read the title of the panel. To the extent that we allow the practice of medicine, whether it's done by wetware or hardware, to become proprietary, and the business model changes from the way the learned intermediary or the licensed professional is the practice of it manages, regulates the practice of medicine, to we have to invest in these machines and this hardware and feed them our data in order to create something that is inscrutable and has commercial motives that we would not ascribe to that practitioner, then the problem becomes what Christo just answered. But if you look at it as medicine, then you say, well, we have traditions and we have ways of mitigating risk in the face of uncertainty, and we have high transparency every step of the way. So even asking the issue of transparency, if all the data is out there and you can reproduce the machine, then it's transparent. Just like if all the data that trained that neural network is out there and you can reproduce the outcome the way you would reproduce a medical study, that's what there is.
And I just wanted to note one other thing that I think is just and I'll be very quick, in terms of the theme of watching the watchers, because I think that's a big theme at a privacy conference, is we know that we're all being surveilled. How do we watch the people surveilling us? What a lot of these debates about, I think, reproducibility, accountability, and explicability or intelligibility of the algorithms come down to is they're watching us, they're gathering data, but to what extent do we retain the capacity to watch what they are doing? And to give an example of that being done in a highly technical context, you could look, for example, at the Securities and Exchange Commission rules on high-frequency trading requiring time stamping of the different transactions. So you could potentially unwind something that happens that's, say, catastrophic or something. And I think if we can do that with respect to financial transactions, we can aspire to do that in the algorithmic context, to watch the watcher, to understand what's going on in these systems. But I do respect Christo's point that some of them are going to be unintelligible. All right, Chris.
So I'm very worried about these proprietary algorithms, and one of the things that I'm thinking about in context of this is conflict of interests. For example, you've got the likes of Jonathan Bush, who has Athena Healthcare and who purchased Epocrates a couple years ago, and Epocrates is one of the most popular apps for prescription data of docs. So there potentially are algorithms for which meds might be overprescribed under those circumstances that you wouldn't know about, and that would change and alter the way a doctor is doing his work. Secondly, again, with all payer claims databases, the context of which I'm worried about is in 2008, a scenario existed where then a company called Ingenix, which is a subsidiary of United Health Group, basically collaborated with insurance companies to cause problems with what's called balance billing. They lowballed the cost of care that was outside of network, causing more money that the patients would have to pay as a result. They got in trouble. They had to create a new database that has median prices of usual, customary, and reasonable care. But in the end, these prices of healthcare, which are in these databases, are trade secrets. So, I mean, the ironies of all this have everything to do with the fact that all this data is uploaded without consent. So I'm just curious about these concerns about potential conflicts of interest, especially under context where all this data that is being delivered to companies could be repurposed and misused, and we have no idea.
And I see that we're running short on time, so I'm going to ask the panelists if you have like a quick response, and then I'm going to get the last two questions, and then sort of possibly a quick response to those. So can we do it all in 5 minutes? I hope. But yeah, quick responses?
So I very much share your concerns to the extent that this is a black box system, and that can be a smokescreen for negligence, if not outright fraud, in the case of something like billing. And this is why I'm such a proponent of transparency and mandates for auditing requirements, that somebody has to look at these systems to vet them.
Chris's question, I think, is a legal one, not a machine intelligence issue. And I would duck it to you.
All that I would say is that if we look at, Ben Goldacre's work and others about the manipulation of results from pharmaceutical trials, that is an extreme warning that we need to be very cautious about the data going into these systems. I mean, it's really, the more one learns about the way that the results are presented, the more worried one gets. So let me just get these last two questions in, questions or comments, and then we'll...
I just have a quick comment, actually. While, the automation, the AI, the algorithms, they are excellent tools in terms of, diagnosing and, in the clinical arena. I feel that the clinicians, these are the tools that need to be used to augment the clinical decision making and not totally rely on these, as you all had mentioned, to just kind of make just random. The machine, made the decision, so therefore it is correct, so you blindly go. Again, then comes up responsibility, who's responsible, what are the liabilities? So all those issues do come up. The bottom line is these tools need to be used as augmentation for clinical decision making by the clinician. So not just relying on the machine. So that's just...
Got it. Sort of a learned intermediary vision. And yes, yeah.
Yes, thank you. I'm Joe Kanatachi. What I wanted to point out, and it's comments more than questions, first of all, it's either I'm growing very old, or else we've got we've done absolutely no progress since 1986, 1988, because it was in 1988 that I published a little book on liability and responsibility for expert systems. So and most of that work was devoted to medical expert systems. I was working out of Norway, but in collaboration with the Austrian Institute for Medical Cybernetics. And I think it would be useful to revisit some of the arguments we were working on then. The second thing is then, if I'm suggesting that we revisit them, how? So I'm going to take this opportunity to make an announcement, which I hope will please a number of you, which is that wearing my hat as UN Special Rapporteur for Privacy, I have determined that we are going to have a set of 5 priorities. I'm calling it a set so nobody can think of which is number 1, number 2, number 3, number 4, number 5, because they're all equally important. I was torn even, but I'm sure many of you would be pleased to know that medical data is one of those 5 top priorities, and that what I plan to be doing is putting together a task force of the good, the great, the brave, the clever, and the insane, in order to try and take this forward. So first of all, any of you in the room, any of you outside the room who may be listening to me, any of you who want to volunteer for this, please do so. Thirdly, could I half in jest, but half in jest only, disagree slightly with the gentleman who said it's our brain and it's inscrutable, and you'll permit me to be anecdotal about that. So when I was setting out on the studies I described before around 1986, and that is why I feel that perhaps we haven't done as much progress as I would have liked to, I was actually teaching myself Lisp and Prolog and all kinds of stuff of what we used to call 5th-generation languages then, so that I could actually write a ready expert system, as we used to call them. And of course, in line with the previous speaker, in order not to upset those of my colleagues who were telling me, so Joe, are you actually writing systems to put lawyers out of business or doctors out of business? And the whole thing of, so we used to call them decision support systems, right? It's still fashionable to call them decision support systems in some quarters. But what quickly happened, and this is to reinforce the black box side of it, which is how I'm only half disagreeing with you, sir. Expert system shells came along. So I would have to learn how to write in a shell, and then the shell is doing something. And the extent to which I was trying to come up with a hybrid model. In other words, for those IT people in the room or outside the room, I was trying on the one hand to use what we would call rule-based systems on the one hand, if-then solutions, and on the other, blending those with neural networks. So, of course, the minute that you do anything with neural networks, as the gentleman correctly said, we can give you a result, we can show that it is correct 80, 90, 95% of the time, but why we've got that result, even mathematically, it's almost impossible to show. That's one thing. Does that mean that we shouldn't use it? No, if it can be done, right? There are several medical cases which can be shown that it can be useful. On the other hand, is our brain inscrutable? And the answer is increasingly no. We have set up, and those of you who are interested in pursuing this further, we have set up a very long time. The questions I have just raised led me to ask myself the question, is there such a thing as a legal brain? Is there such a thing as legal reasoning? And how do we get towards machine representable forms of legal reasoning? But of course, there's medical reasoning. And what we're talking about here is also medical reasoning. And what we have been doing increasingly, certainly in one of my departments and one of the teams which we collaborate with, is introducing cognitive science into our work. We were amongst the first departments to hire full-time cognitive psychologists, and the whole reason here is to try and understand where, at this moment in time, how we are making decisions. And this is something which has increased greatly, and had this been a legal conference and not a medical health informatics conference, I would also be saying, think about some of the implications. I mean, just a quick poll. How many lawyers do we have in the room? Okay, now all of you will remember that they taught us a couple of things, right? One, that you can only be held criminally accountable for an action if you had intention, the so-called mens rea. So how do we account for the fact that cognitive science is telling us that we have made decisions 7 seconds before we are aware of the fact that we have made a decision? And in that case, how can I be held accountable? Or am I going to be held only accountable for the filters I bring in on taking that decision, right? Whether it's